just like to introduce Sam Rooney. Sam is a senior physiotherapist at the University Hospitals Birmingham NHS Foundation Trust. Sam is also a trustee for the Society of Tissue Viability and is going to talk to us about the role of mobility in reducing pressure ulcer risk. So over to you, Sam. Thank you.
Hopefully. So yeah, I'll go back. So yeah, so this is the title of what I'm going to talk about for the next half hour, hopefully, and I'm hoping it's not going to be a repetition of anything you've heard already today. So we're going to review what mobility means and the importance of it, and then explore the effects and impact of immobility and early mobilization. And throughout, we're going to relate that to any current evidence that's out there. So first little question for you to think about, and feel free to put stuff in the chat or to just think about it in your own time. But what does mobility mean to you? So we use the phrase an awful lot, and it will mean different things to different people. But think about what mobility means to you. So the Oxford English Dictionary definition is that mobility is the ability to move or be moved freely and easily. And if we think about the international guidelines, mobility refers to an ability to change and control one's body position. So when we're thinking of a mobility impairment, we often refer to a reduction or a deviation in the type of frequency of movement, including bed and chair and walking, ability to maintain specific body positions. So that's just something to bear in mind as we go through. So why is mobility important? So little question for you to think about again. On average, how long does an adult in the UK spend sitting? And this is from an NHS project called Why We Should Sit Less that was published in 2022. And the answer to this is 9 hours. But actually, all of them are probably correct. And if you add injury or illness on top of that, people could spend up to 18 hours sitting in a 24-hour period. So we think about the sustained effects for increasing sedentary behavior. So the more we sit, the more effects we're going to have on our body systems. And this is a physiological review that highlights that there's cardiorespiratory system involvement, metabolic involvement, so your gut and your hormone responses. There's changes within your adipose tissue and within your musculoskeletal system and your cardiovascular system. So bear those in mind because we'll revisit some of those as we go through this presentation. So bearing that in mind as well, at what age does physiological decline start? So again, think about this in relation to yourself and in relation to patients and everybody else. Again, if you wanted to put stuff into, I can't see the chat just yet, but if you wanted to put stuff into the chat, then you are more than welcome. I'll give you a couple of seconds to think about that.
If you can't see it, Sam, most people are saying B, 30.
Yeah, spot on. Excellent. Thank you, Sarah. I can't see the chat and my presentation at the same time, which isn't helpful. So then if we think physiological decline starts at age 30, this is figures taken from the Office for Health Improvement and Disparities, again, published in 2022. So people over the age of 65 have an increased risk of fall, but how many people over that age fall per year? And again, chat would be useful in this one.
A mixture, really. A lot of C's, 1 D.
Okay. So it's actually 1 in 3. And if we look at the over 80 population, that increases to 1 in 2 will have at least 1 fall per year. So we know that falls have got an increased risk of injury, which is going to have an increased risk in terms of immobility and that patient's ability or that person's ability to function. So although we're focusing on pressure ulcers, there are other things in terms of harm and risk that can be detrimental to people. So this is first systematic review that looked at patient risk factors for pressure ulcer development. And the most common independent predictors were mobility and activity, perfusion, and the skin and pressure ulcer status. Benefits from numerous studies that were reviewed increased the reliability of the results and conclusions of this, but there was so much variance in the studies that it was hard to pull them all together. But overall, those were the factors that can independently increase your risk of pressure ulcer development. So 36 of the 54 studies included one or more mobility or activity related variables in their analysis. However, the relationship with poorer mobility increases the risk of pressure ulcer development. So nothing that we don't know already. So when we come to our guidelines, we've got NICE guidelines and pressure and the international guidelines. Mobility is identified as a significant component in terms of risk in relation to pressure ulcer development, or rather the impact of immobility is the risk. So it's the limitations and restrictions to mobility that are highlighted as a significant component to pressure ulcer development. There are obviously higher risk groups of patients, including spinal cord injuries, obesity, in theatres, in transit, in ED and trolley weights, etc. And mobility is referred to in all aspects of the guidelines around risk assessment, care planning, and it's well recognised that if we can maintain mobility and functional activity, it's a key component to preventing pressure ulcers. So what is the physiological impact of immobility and bed rest? So also cast your mind back to that earlier slide around the impact of sedentary lifestyles, where we've got multiple changes on multiple body systems. I'm going to just focus on these just in terms of time. There are loads of other ones to consider, but these are possibly the biggest ones that might have an impact on mobility. So on average, for every week of bed rest, how much muscle strength in percentage do we lose? Again, if you want to share in the chat, that would be great.
We've got 33, we've got 10.
Yep.
15.
A bit of a variety.
1.5% every day, 115. Gosh, really.
Wow.
55, 7, 15, lots of different numbers.
Lots of different numbers, which is great. And again, probably none of those are desperately wrong, but on average, it's 4 to 5% loss of muscle strength per week of complete immobility and bed rest. So that's not weight bearing at all. So if we add that into our physiological declines that starts at age 30, if we add in a period of bed rest and the loss of muscle strength, we can see quite easily how the impact of muscle strength is going to have on our mobility. Unfortunately, the fitter you are and the more muscle strength you have, the quicker and more rapid your decline, but it will plateau out at a certain point. So respiratory wise then, if we're thinking about our functional residual capacity, so the amount of air that's left in our lungs for us to breathe at a tidal volume rate, that reduces significantly from being upright to being lying down. So from about 77% to about 32% from sitting up or standing up to lying down. And that's going to have an impact on our VO2 max per day. So that's the maximum amount of oxygen we can take into our system over a day. And again, guesses in the chat as to what that reduction is per day in percentage. So the reduction in our ability to metabolize oxygen.
We've got 2, 7, 10, 3.
I'm loving the variety of answers. This is great.
5 to 10, bit of a range, 8%.
Yeah.
A lot of people, I think, are just sitting on the fence.
Yeah. So yeah, which is fine. That's absolutely fine. It's just I'm just hoping to get people thinking about things differently. It's a 0.9% decrease in our VO2 max per day of complete immobility. If we add into that our decreased lung volume, it's going to affect our ability to do a deep breath and a cough. I work on critical care, and that is a big factor for us in terms of maintaining respiratory function. If our respiratory function is compromised, then when we do come to exercise and we do come to move, that ability to take in oxygen and deliver it to the musculature where it's needed is compromised. So fatigue is then a massive issue and limits what we can do with patients. And that's the same with any injury or illness or any period of immobility. So circulation wise, we've got a little thing called Verco's, I think that's how you spell it or pronounce it, triangle. And that is where our blood increases in viscosity because the plasma volume decreases over time. We get increased hematocrit, and that then creates risk factors for DVTs. If we've got a DVT, it's going to be painful. People aren't going to want to move, which impacts our mobility further. So for this one, after a week in bed, so immobilized in bed, what percentage loss of plasma volume will you have?
Okay, so we've got lots of 5%. We've got a 10%, a 10 to 15%.
Yeah.
15 to 20%.
Yeah, so for that first week of immobility, it's about 10% loss of plasma volume. And over a 4-week period, that it doesn't continue at a 10% loss each week. It's a 10% loss of what you've got. So over 4 weeks, it'll be up to 15%. So again, if we relate that back to our respiratory and muscular system, we've got a decreased circulating volume. We've got a respiratory system that's compromised and can't take that oxygen in for gas exchange. And then we've got a circulatory system that isn't going to be able to deliver that oxygen to our muscles when it is into the system. So bone-wise, so we'll start to get bone changes and a reduction in bone mass. So this is a bit more a longer term. So for a month of immobility, what's the decrease in our bone mass?
5, 8, 1 to 1.5, 6, 5.
Yeah, so on average, it's about 2% of bone mass loss per month. But the bit that's tricky with bones is that it can take up to 2 years for that bone demineralization to recover. So if we're thinking again from a fragility point of view, we've got compromise in our bone structure, we've got compromise in our muscle strength and our cardiovascular fitness, increased risk of falls as we age, unfortunately. So if we fall and we haven't got the muscle strength and we haven't got that protective ability, are we more at risk of fragility fractures, which is going to give us an increased period of immobility and bed rest, and the whole vicious cycle starts again. So I've put there, so it's about 1% loss a week, but about 2% over a month. And then if we think about our cardiovascular system, that's our last one. So our cardiac function. So your heart is a muscle and it is subject to deconditioning like any other muscle, but it is affected slightly differently. So for 10 days bed rest, and I'm aware that these are all different timescales, but this is where the research is at. So at 10 days of bed rest, what percentage decline in cardiac function do we have? So that's the ability of our heart to pump blood around our body. Any answers in the chat for us there, Sarah?
Sorry, I've been on mute there and I've been rabbiting on.
Excellent.
A really mixture, 5,
Yeah.
6, 3. Someone says 10 to 15. Yeah, 2% mixture.
Yeah, so this, I think this for me is one of the most shocking ones. So it's it can be up to 28% decline in cardiac function over a 10-day period of bed rest.
Oh, well done to Rosie. Rosie said 25%.
Oh, well done, Rosie. Excellent. Yeah, so again, if we put all of these factors together and that one system is going to be affected, it's going to be all of those, and they're all very, very closely interlinked, and can have a huge impact on our ability to mobilize. So hopefully that has given you a little bit of background, and this is all research that has been done on healthy individuals, so not our already compromised patient groups, for a lot of us. So if we add in age and frailty and comorbidities, these figures are going to be potentially a little bit more significant. Okay. So we'll move on to have a little look about rehab and early mobilisation, and what evidence is out there to support things around rehab and early mobilisation. So this is all relating to when patients are either admitted to hospital or within a care facility. So this isn't the prevention side of it. This is, well, it is prevention in terms of the sooner we can get people moving, the better it's going to be, but it's not preventing that hospital admission or that care facility admission to start with. So if we look again to our guidelines, the advice is to implement an early mobilisation programme that increases activity and mobility as rapidly as tolerated. And NICE have a guideline for rehab after critical illness, and they advocate an early and structured rehab programme for patients admitted to critical care. So the general advice is to start things as soon as we can, as soon as it's safe, and progress as quickly as possible. So these are some studies that have been done in critical care, but these are probably the most frail of patients, or the most critically ill patients. And these are looking at both, one of them is a systematic review with a meta-analysis, and the other is a meta-analysis. They're both from China, so may not be fully translatable into the UK, but I think the messages around the implementation of early mobilisation is quite significant. So for their critical care cohort, they found that the number of patients able to stand on discharge from ITU was significantly increased from 62% to 90%. The number of days, or the sooner patients got off mechanical ventilation and vent-free breathing days, was increased. One of the things that we've hopefully highlighted from a period of immobility is the incidence of specifically ITU-acquired weakness. There's a neuropathy component to ICU-acquired weakness as well as a musculoskeletal one, and the incidence of that for this cohort was decreased. And more people were walking, able to walk whatever distance at hospital discharge, and that related to an increased percentage of patients being discharged home. The meta-analysis from Zhang et al. In 2019 showed all of those things, as well as a reduced incidence of DVT, ventilator-acquired pneumonia, hospital-acquired pressure ulcers, and improvement in physical function using the Bartel index. So this is one of the first meta-analysis for critical care patients that have looked at the reducing incidence of hospital-acquired pressure ulcers. However, these studies are really quite small. They're low quality. It's very, very difficult to undertake randomized control trials on critical care because of the heterogeneity of the patients. So every patient that is admitted, even if they're admitted for the same reason, is going to present slightly differently. So difficult to interpret, but the overall message is that exercise and early mobility is good. these 4 studies looked at, so these are again systematic reviews and meta-analysis, so pulling all of the evidence out there together. And these looked at the effectiveness of early mobilisation, specifically on pressure ulcer prevention and management in intensive care. But none of these studies were able to identify that getting out of bed, implementing a seating regime, or adopting a early mobilisation programme as a repositioning prevention was of any benefit, unfortunately. But hopefully. Well, we've got some positives coming up. So this is an article that looked at the overall management of patients from managing pain, agitation, sedation, delirium, immobility, and sleep disruption. So all of the things that are massively impactful for any patient, but specific, again, focusing on ITU. I think a lot of these principles can be translated into a lot of other patient groups. And what did they find? So they suggested performing rehab or mobilisation in critically ill adults, and that is standard practice in the UK. And the group that they looked at without early mobilisation as a component of their care, there was a 5% difference increase in the pressure ulcer prevalence in that cohort of studies. So this was a prospective study, so they looked at patients in real time, and they looked at 1,855 patients over a 3-year period. So this is a massive study and has quite a lot of weight behind it. They also identified that serious safety events or harms don't happen commonly during physical rehab or mobilisation, and they provide some parameters around what is deemed as safe, a safe point in time to start to implement these programmes. And that is to do with the cardiovascular fitness of the patient and stability, and whatever condition they've been admitted with is a stable condition. But they also showed a reduction in length of stay, a reduction in the time that they were on mechanical ventilation, which therefore had an impact on cost and the hospital stay in generally. So then this is another one that was published in 2020, and unfortunately, they didn't come up with a specific conclusion, but they did say that it was a positive trend towards decreasing hospital-acquired pressure injuries with the implementation of early mobilisation programme in 3 of the studies that they looked at, but the opposite findings were true in another 3 studies. But again, these studies were, they had low methodological quality, so that made it hard to come up with a definite conclusion. And again, there was a significant heterogeneity, which makes it complicated to interpret and apply it to a wider population. But the other thing out of all of these reviews and studies was that what is defined as early mobilisation and when does early mobilisation start? And that wasn't consistent at all in any of the studies. So again, difficult to interpret results and difficult to take things forward. But overall, the key message is early rehab mobilisation is a key component to improving patients' overall physical health, which decreases their risk of acquiring pressure ulcers, hospital-acquired pressure ulcers. So this is just a little slide to say, okay, well, that's all well and good in decreasing risk, but what's the impact of mobility on wound healing? So if a patient's already got a wound or a pressure ulcer, and this wasn't specific, a lot of this research been done in venous leg ulcers, but again, hopefully there is some translatable evidence into a more general population. And all of these studies found that a specific guided exercise program, rather than just giving patients a booklet or advice about exercise and expecting them to go off and do it themselves. All of these studies found that there was a reduction in healing time and an increase in the number of wounds that healed within a 12-week period. So a graded mobility and resistance exercise program was really, really useful in terms of wound healing. So not forgetting the psychological impact of reduced mobility or immobility. So a lot of the time, the psychology of a change in physical function is going to impact on patients' ability or people's ability to undertake mobilization or exercise programs. When we've got changes within our skeletal muscle mass and changes in body image, that can have a massive impact on people's perception of self, as it's quite a significant change. If we've got the impact of reduced mobility or immobility, their role within their own role with as in their own self, but within family, within social circumstances, within employment category will also be affected, and that's going to have an impact on their self-worth and how they value themselves, which is going to have an escalated impact on their mental health and motivation for undertaking any mobility exercise or activities is going to be key. So again, all of these things linked in together, we can see how it's quite a downward spiral, but hopefully if we can access things early and provide the right education and support for patients, then we're on to a winner. And just a question, this is just a question to take away with you. So support surfaces, as in alternating air mattress support surfaces, or air mattresses generally. So do we ever consider that a support surface may be restricting someone's mobility? This is a conversation I probably have on a daily basis, in that an air mattress just is not allowed, it's not a firm enough or supportive enough firm surface for a patient to be able to undertake that independent activity. But we've got to strike that balance between their risk of pressure ulcer development and mobility. But if a patient can be more mobile, does that reduce their risk? So I'd say that's just a little thing to think about and take away. And so in summary, move. So the more we can move, the more we can keep active, the better it is going to be. And I think that should be bang on time.
Absolutely bang on time. Even a few minutes early,
Oh,
Sam, but that was perfect. Yeah, got us all thinking there, didn't you, with all those questions? That's great. And I think it just highlights, I think that often people associate immobility, the risk is just the pressure, but you sort of going through all of those, the circulatory, the respiratory, the muscle mass. It's really food for thought, isn't it? And it's quite depressing. Actually,
if we think about it too much, if we think about it too much, it can get quite depressing. And unfortunately, it is the process of aging. And unfortunately, people are living for longer and with more comorbidities. So, I've got another statistic somewhere, but I can't remember exactly what it is. But by 2040, the population of over 75s is going to be the biggest demographic in the UK.
Wow.
And I can't remember the percentage of it, but it's quite a humbling and take a step back and think about things kind of statistic. And alongside advancing age comes comorbidities. And as good as medical research and treatments are for various different illness and ailments, I'm not sure it's going to catch up in the next 15 years.
No, and it's all fine, isn't it? If that's the statistic, as long as people are well. I mean, if is the new 70 is the new 60s. If people keep well and mobile, it's not going to be a risk to us as the NHS or whatever so much. But I suppose it's about public education then, isn't it? About keeping us as well and as mobile as they can. Because we think of mobility, don't we, as people on their legs walking, but of course, it's important to sort of think about how we can keep people mobile that can't walk, I suppose.
Yes, yeah. So when I was trying to figure out the definition of mobility, that's where it's the ability to maintain and move. So it's not just about getting up, it's about body position. So whatever that body position is. And if it's sitting, how do we get the right support into sitting? Because we all know we sit up with a lovely posture for about 5 minutes and then gravity starts to act and we start to slump and we stick a leg underneath us or we cross our legs and then that changes everything. So it's a massive challenge, and I've just been having a quick little read of thank you everyone for your very kind comments.
There's a question from Karen about how do we get it right for patients to reduce their risk when being admitted into hospital for an acute admission when wheelchair dependent in the community and already at risk of pressure ulcer?
Yeah, so we are currently trying to get a piece of work done alongside our electronic patient record because we have exactly that risk. We have a high cervical complete spinal cord injury who is a frequent admission for a variety of different reasons, but every time they come in, and I'm sure it's the same in other places, ED wait can be incredible. And he's been admitted 6 or 7 times since February. And on one of those, he developed a CAT2 on his sacrum and on both heels because of his ED weight. And we know, and everyone knows this guy because he's such a frequent flyer, as it were. But we're trying to work with our electronic patient record system to pick up a little tag. So we've got them for infection, we've got them for safeguard, and we've got them for various other different bits and pieces. But we want a little alert to say that this patient needs to be admitted to ITU as soon as possible because he's ventilator dependent. We can't manage that on the wards, and he needs to be moved. When he is well, he will tell people he needs to move. When he is not well, he will not because he's unwell. So it's such a challenge. And the complexity that goes with wheelchair dependency is, I'm probably not giving you a straightforward answer there. But yeah, education into ED, I think would be that, and we've got another project running alongside it in ED about repositioning and etc. So
yeah, I mean, Rosie's probably along the same sort of lines here. Made this comment about hospital-associated deconditioning is the new pandemic. You know, the biggest reason for why people get pressure ulcer, hospital-acquired pressure ulcers.
In answer to your question, Karen, yes, like an alert in their medical notes. Yeah, we're predominantly paperless here. There are a few things that are still paper-based in our trust. But as I say, we have infection control alerts, we have safeguarding alerts, we have learning disability alerts, so that when a patient is admitted, they automatically flag up, and we're trying to get it for our, we're starting small with our recurrent readmissions with spinal cord injuries, but it's going to take a little bit of time because it's an electronic system and things don't happen quickly, unfortunately. But lovely, you're a specialist nurse in spinal cord injuries. I should have put my email address on my presentation, but I'll put it in the chat, and absolutely link in with us. We have a very nice little spinal cord injury team here in the West Midlands, so that's my address, my email address. So if anybody wants to touch base or keep in touch, that'd be great. Rosie, yes, absolutely, risk averse. Yeah. So Rosie's comment in the chat is, it's so important to find out what normal mobility function is for people on admission. Staff are often risk averse with complex or frail patients, and they stay in bed, and then a few days and damage is done. Yeah. Yes. Apparently it's easier to care for someone who's in bed than it is if they're sat in a chair and can get into a chair by themselves. So yeah, it's hugely important, and we sometimes don't always ask those questions because the nature, unfortunately, of acute care. And I know I'm focusing a bit more on acute care, but it comes back to the two questions, and there probably should be a third question: is, are we really asking? Because a lot of the time it's like patients get admitted, we sort out the problem, and off you go, and then that's where the problems start. Because are you ready for discharge, but you've got a pressure ulcer because you've been in bed for 10 days and not really moved. So
I
thank
think,
you.
there's also, Sam, my concerns, and I'd like to think it doesn't happen so much now, but certainly, when I was in clinical practice, there was a lot of, if people had very complex sort of category 4 pressure ulcers, say on their sacrum, it was they need to go on bed rest. And one to me is, who would really want that? Well, maybe for a day I'd quite like it. But it's about sort of quality of life. But also then, as you said, they then lose their muscle mass, their cardiac function,
their bowel mobility.
It still happens, doesn't it? People are put on bed rest.
Yes, and in certain circumstances, it will be the right option for that person. But you've then got to deal with all the other consequences, and actually listening to what your patient is saying, or the family or the carers. It's tough and it's hard, and it sometimes doesn't sit right, but it's what is important to that patient and what do they value, what's their quality of life be. If they've got a cat 4 pressure ulcer already, their quality of life probably isn't the best. And it's how we can support, and again, there's no right or wrong answer, it's how we can support the best to support that patient and to keep them as mobile as possible, even if that is their ability to roll over in bed. I
think on that note, that's a very positive end. I don't think there's any other questions, but lots of
lovely comments. Thank you so much, guys.
Fantastic session.